Okay. So after the nice demo by Julien and Kai, let's come back to the talks, and we should talk about an abnormal cardiac position, as you see here. So first of all, looking at this for chamber view, who of you says it's normal, and who of you says it's abnormal position? You think it's normal? Yes? No? Don't know? Normal? You can't say, because I have to tell you whether it's a breach or whether it's a vertex, because otherwise you may have a situs inversus, so you are not able to find out. So the first issue is that you cannot tell what your eye sees, but you should refrain from that and trigger your neurons, hyperglycemic neurons now, and define first the fetal position in utero, and then decide what is left and what is right, and then confirm that actually the apex of the heart is pointing towards the left part of the body, and that the heart is mainly in the left hemithorax, as you've heard this morning, according to the guidelines. So, going into the terminology, the cardiac axis defines the orientation of the apex of the heart within the thorax, regardless of its position. And the terms used to describe this cardiac axis are levocardia, if the cardiac axis points to the left, and the normal range is roughly 35 to 65, if you add the 20 degrees, which is the standard deviations. Mesocardia, then, if the apex is between less than 25 degrees towards the left and 0, of course. And dextrocardia, if it's on the other side. So it's if the cardiac axis is reversed on the other side. So this is levocardia, and you do not need to measure the actual axis unless you have any doubts that it is increased or decreased actually. This is a mesocardia, in which the axis sometimes cannot even be measured because it's 0. Okay, like in this case it's just a few degrees if you compare the orientation of the septum with that of the midline. And dextrocardia if the apex is pointing on the other side, as in this case. Okay, so this is as far as cardiac axis is concerned. Then we have the cardiac position, which describes the location of the heart within the thorax, nothing to do with the apex of the heart, even though the two things in some of the cases go together. So you have a levo position, which is the normal position of the heart in the hemithorax, in left hemithorax, meso position if the heart is in the middle of the thorax, and dextro position if it's on the other side. So this is levo position, normal situs solitus and levo position and levocardia. This is meso position, and this is dextro position. As you see here, as I will tell you in a while, most of the dextro positions of the heart will be due to extracardiac abnormalities. So a clue for diagnosis is that an abnormal cardiac axis, so an increased or decreased rotation of the heart within the thorax, is mainly seen in heart defects, namely conotruncal abnormalities and cardiosplenic syndromes, whereas an abnormal cardiac position is mainly seen in non-cardiac abnormalities, lung mass, pleural effusions, and so on and so forth. For example, in a hernia, you see here is this dextro position or levo position. Again, you cannot tell unless I tell you that this is a breach. So if this is a breach, then the heart is on the right, and this is a huge diaphragmatic hernia on the left, and the stomach is displaced towards the right side of the thorax because of the huge herniation of the liver. Quite similar image, but the reverse is true. In this case, it's a vertex, so this is the left. Again, a hernia, but in this case, it's the right-sided hernia. This is the hepatic flexure of the colon, you see here. The liver in the thorax again. But again, you see the two images are quite similar, but the heart is in completely different position, and this is a left-sided hernia, and this is a right-sided hernia. So consider again and again the position of the baby in the womb. A CCAM, type 3 or a hyperechoic lesion of pulmonary sequestration whatsoever. This is type 1 microcystic. And you see how the heart passively is dislodged from its usual location towards the other side, or squeezed along the ribs in this case. And another case in which there was a huge pulmonary sequestration. This is the normal lung, which is compressed by the hypertensive hydrothorax on this side. This is the extralobar sequestration, and here is the pleural effusion that you see together with the sequestration as displays the heart contralaterally. And also another case, in this case, was the single pleural effusion to be responsible for the displacement of the heart. Sometimes you have less obvious abnormalities which may be responsible for dextrocardia. You see here, 20 weeks of gestation, this patient was referred because of apparently pericardial effusion. But you see here that the heart is mainly in the right hemithorax because this was a vertex. And there was indeed some fluid around, but this was not within the pericardial cavity. It was outside. We waited for a few weeks, and again the abdominal view was unremarkable, and the stomach was in its proper location in the left hemi-abdomen. But in this case there was a left-sided hernia without the herniation of the stomach. But you see here, you may make out some ileal loops. All this echogenic spot here are ileal loops, and with the moving image you would see this more effectively. So in case of isolated diaphragmatic hernia, the message is to consider, isolated dextrocardia, you should consider diaphragmatic hernia in the differential diagnosis. This is quite important for you. Again, less obvious extracardiac anomalies. The heart looks normal, or rather so. The tip is towards the left because this is a vertex, even though I hadn't written it here. But you see, the heart is completely in the left hemithorax. Who says what it is? Scimitar is only on the other side, on the right side. Is that an hernia? No. The colleague here told it was correct. This is a left lung agenesis. So in this case, the heart was completely moved towards the left hemithorax because the left lung was completely absent. And this is another such case, but in this case it was associated with severe asymmetry of the thoracic cage, and you see here that there was no way to displace a single pair of rib to get an actual view, but there were several pairs of ribs because there was a hemivertebra and there was a kind of a complex abnormality of the thorax. An obvious cardiac abnormality is responsible for an increased cardiac axis. First of all types of lesions leading to cardiomegaly are associated with an increased cardiac axis. Is the reason why it is so, you see here, because the thorax cannot accommodate the heart when it's larger than it is usually, so it rotates on its axis and is called now what the pediatric cardiologists name side-by-side heart, or wall-to-wall heart, from one set of ribs to the other set of ribs. So whatever reason the heart is enlarged, in this case I have a pair of abnormalities. This is the classic setting of pulmonary atresia with intact ventricular septum and severe insufficiency of the tricuspid valve leading to severe atriomegaly and consequently cardiomegaly, and you see that the axis is roughly 90 degrees. And the same applies to this severe case of Epstein. You see the tricuspid valve is completely displaced towards the apex here, and the heart sits horizontally, completely tilted towards the left side of the thorax. This is another case of a very rare. This was the left ventricle, a right ventricle here, and this was a huge aneurysm of the right ventricle. Also in this case, the heart is wall-to-wall. Less obvious cardiac anomalies, I would say less obvious rotation of the cardiac axis. In this case, you have the impression, but if you do not measure it, you may overlook that the cardiac axis is increased, and then it's roughly 50 degree probably. And you see here, and in this case, it was associated with absent pulmonary valve syndrome together with tetralogy of Fallot. In this case, you see that the pulmonary valve does not exist as such. It's just transformed into a fibrous annulus, which is responsible for severe stenosis and regurgitation at the same time. You see the severe insufficiency of the fibrous annulus of the pulmonary valve, and at the same time severe stenosis with the blood flow jet circling around the two branches of the pulmonary artery. Increased cardiac axis is also associated with canal truncal malformation. Again another one, and you see again the increase of cardiac axis. And in this case, there was a truncus, common arterial trunk. You see here huge single vessel arising from the heart, malalignment VSD, this plastic valve consistent with diagnosis of common arterial trunk, and then you put on the color Doppler and confirm that the truncal valve is stenotic and insufficient at the same time. And this was associated with microdeletion as well, and DiGeorge syndrome. And now, going towards the end of this brief talk, look at these two images, coming back to the D and L transposition that was mentioned earlier this morning. And in this case, of course, if I say that this is the right side of the baby, then you see that the moderator band sits on the other side. So if I should name and tag the four chambers, then this is the left atrium, this is the morphological left ventricle sitting on the other side, and then this is the right ventricle, morphologically right ventricle sitting on the left side of the heart, and this is the right atrium, of course. However, you see here, as I was telling you here, corrected transposition can occur in situs solitus or inversus, with or without dextrocardia. So it's not quite easy to tell what is left or what is right, if it's situs inversus or if it's isolated dextrocardia with transposition, corrected transposition. And again, this was again a vertex, so the heart is in dextrocardia and dextro rotation of the apex, and you see here that in this case there was the aorta was on the right, so this should be situs inversus. So this is the left atrium with the two pulmonary veins, so you put an anatomical confirmation that this is indeed the left atrium, and the morphological left ventricle is on the other side, which is the left side of the baby. But since it was in situs inversus, the situation has reversed, so it's wrong position. And again, this is the right atrium, and this is the right ventricle. So you see that in this type of setting, you, at the end of the day, if you do not know what is the position of the baby, you have a lot of difficulties in understanding whether you are confronted with the CTGA in situs solitus or in situs inversus, and with or without a dextrocardia. And these are the corresponding images. And finally, an abnormal case of cardiac position in axis. You see this heart sits in the middle of the thorax. And the other thing that you can see, other than mesocardia, is that you see just one pulmonary vein entering in the wall of the left atrium. And this finding is confirmed also with the power Doppler. You see, Julien before and also Kai showed at least two pulmonary veins entering in the posterior wall of the left atrium. This was not the case in this case. And you see here that this is the lesion scimitar syndrome, in which you have an abnormal pulmonary venous return from the right side of the heart, and they reach this connecting vein which drains infradiaphragmatically, and this vein has been tagged as a scimitar So from this, the name of scimitar syndrome. And here is a post-natal MRI angio showing you the image. And this is a B-flow cast, not from the same case. This was from the internet. And you see here the heart. This is the inferior vena cava, suprahepatic veins, ductus venosus. And here is the scimitar coming down from the lung, the abnormal venous return. And finally, the obvious abnormal cardiac position, which is ectopia cordis. In this case, was one twin of a pair of monochorionic twins, so the patient did not want to run the risk of miscarriage of the co-twin and decided to go to term. This is why we have image in the advanced second trimester. And this is the image with grayscale and color Doppler. And this was the specimen after birth of the healthy co-twin. So in conclusion, an abdominal cardiac axis, an abdominal cardiac position and abdominal axis are often associated. Abdominal position is mainly seen in non-cardiac thoracic abnormalities such as hernia or CCAM and other lung problems, or in case of lung hypoplasia or agenesis. On the other hand, as far as heart defects are concerned, an abnormal cardiac position is mainly seen in corrected transposition and in cardiosplenic syndromes. In heart defects, an abnormal cardiac axis is mainly seen in complex conotruncal abnormalities, I would say, rather than in classic tetralogy of Fallot. And for the problem of the accommodation of the increased volume of the heart within the in an anelastic thorax, in all cases leading to cardiomegaly. In case of mesodextrocardia, check the pulmonary veins to rule out scimitar syndrome. And most importantly, and this is the last message, again and again, before starting your examination, before doing whatever, just create a mental replica of the baby in the uterus in that moment. You can also use, you are in an advanced course, but if you want to teach this to other persons in your own country, you can also use a puppet or whatever for you to use as a kind of example to show the juniors in your department how to understand the position of the baby in the uterus. And thank you for your attention. Time is now? Yep. Keep on. Is it still on? No. Okay. Okay, so this is a very short talk on the evaluation of the fetal thymus, and Rabi decided to put together two papers that you should have, I think, in your DVD that we published on the same issue on the White Journal. My dealing with the color Doppler and the best way to identificate the thymus area, which is the thigh box, I named it this way, and he to objectivate the possible presence of hypoplasia of the thymus with the thymus thoracic ratio or TT ratio. A few notes from embryology and anatomy. It originates from a third pharyngeal pouches. It requires an interaction between epithelial and mesenchymal induction between the arch mesenchyme and the neural crest cell. And this is quite important because this is the link between all abnormalities of the pharyngeal arches and the thymus and the aortic arch and the macrodeletion 22, Q11, as I will tell you in a while. And of course, all of you know that it contributes to T-cell immunity and is also an endocrine function. The blood supply to the thymus is provided mainly by branches of the internal mammary artery that you see here in a drawing replying what is the orientation and size of the thymus in the adult. And in the adult, it's very, very small in comparison with prepuberal phase and the fetus. And the veins, of course, drain into the innominate, eventually into the innominate vein and the thyroid veins. The relationship between thymus and microdeletion are shown in this slide. Microdeletion is a spectrum of deletion within this locus here, which are responsible for, as I was telling you before, for a group of syndromes which have taken in time across 20 years or more different names, and then all of them were discovered to be linked to the same abnormality, which is the microdeletion. Velocardiofacial, Spritzen, Kyler, Opitz, BBB, and so on and so forth, and all of them are related to microdeletion 22q11.2. And the most severe of these syndromic condition is the DiGeorge syndrome, in which you have a typical facies, heart defects, conotruncal abnormalities, and or interruption of the aortic arch, type B, of course, hypoparathyroidism, cognitive, behavioral, and psychiatric problems in roughly 1/3 of the cases, and increased susceptibility to infections due to the loss of immunocompetence for T cells. And as I was telling you before, the link between microdeletion and thymus hypoplasia is the impaired migration of neurocrest cells, which determines an abnormal development of pharyngeal arches and pouches. But remember that from studies published in adult and individuals with microdeletion and or DiGeorge syndrome, and this is a problem for us, thymus hypo or aplasia is present in roughly 1/3 of the cases with microdeletion, and not 100%, but 83% of the individuals with the full blast DiGeorge syndrome. Should also consider that it has been described, and there is a paper by Shao as well regarding autosomal trisomies, that thymus hypoplasia has been shown to be present in the fetus in other conditions, such as Down syndrome, IUGR, or PPROM due to infection. How does it look on ultrasound? It has been described for the first time several years ago, actually, in 1989 by Felker. And it is best visualized, of course, on a trivessel and trachea view. And on this view, it appears as a roughly oval structure that you see here, slightly less echogenic than the lungs, with some tiny echoic, tiny spots in its texture you see here. And another thing that helps you to highlight it in comparison with the adjacent lungs is that since it sits on the heart, it transmits the heartbeat, the heart pulsation, less than do the two lungs that you see here. The assessment of the thymus, as I was telling you, has been introduced to derive the risk of microdeletion in fetuses in which a kind of truncal malformation had already been detected. And to this extent, to objectivate the presence of thymus hypoplasia, in the literature also present some papers describing diameters and area across gestation. However, and this we come to the paper that we published from our group, the identification of the thymic area within the upper mediastinum is not only always straightforward, because in some condition, for an awkward fetal position, or due to an increased body mass index, or to a distortion of the upper mediastinum anatomy due to a conotruncal malformation, is not easy. Believe me or not, this is the thymic area, and here's the thymus, but you do not see anything here. If you use this image, you have the borders of the thymus highlighted by the two internal mammary arteries that course parallel alongside the thymus and identify between the sternum in the front, the innominate vein behind, and the two mammary arteries, what I call the thigh box, the area where you should look for the thymus. The issue is that in comparison with the postpuberal age, where the thymus is rather shrunk in comparison with the fetus and the neonate, the thymus does not reach the two internal mammary arteries. However, in its full length and full development, it does reach the two internal mammary arteries on both sides. So you can use these arteries to actually identify the borders of the thymus on either side. And this was the rationale of my how-to papers. And this can actually be seen with color or power Doppler, both with an actual approach because they are oblique, because they just below the rib cage on the sides of the sternum, so they go downwards. So you can highlight them both with an axial approach or with an oblique approach, but also with longitudinal approach. And also Kai, in his demonstration, showed this type of image. So this is one of these cases in the late second trimester. You see here the two internal mammary arteries, and here is the thigh box in between the sternum, the vessels here, and the two internal mammary arteries. So how to do that? First, get the trivessa and trachea view, switch on color Doppler, and sweep slightly a few degrees up and down until you find out the two internal mammary arteries. You can do it with color Doppler with reduced PRF or with power Doppler, no matter, but you will see them once you're familiar with this type of technique. This is quite important for you to be confident that there is a reasonable amount of thymus in front of the neck vessels here. And once you've become familiar with the technique, you can also apply it in early gestation. And these are two cases, transvaginal examination. You see here the two dots of the two internal mammary arteries in front of the neck arches here, and this is another case. So the advantage of this technique is that it allows clear identification of thymic area also in early gestation and in case of difficult visualization. For example, in this case, this was the same gestational age, normal baby, a baby with the canal truncal anomaly and microdeletion. You see that the thymus is small, and you would like to see what are the borders of the thymus. And then you use the two internal mammary arteries, and you see that this is the thymus. The disadvantage of this technique, it was not meant to give an objectivation of the degree of thymus hypoplasia, but just to highlight the area where the thymus is or should be. And this is where the TT ratio comes, because this is a way to objectivate the degree, the presence and the degree of the volume of the thymus. It was described by Rabi in the same issue of the White Journal, as I was telling you before. Get the trivessa and trachea view. This is his original drawing here. Measure the anterior-posterior diameter of the thymus and up to the anterior aspect of the aortic arch here. Measure the anterior-posterior diameter of the thorax between the sternum and the body of the rib. And the normal values are 0.44, the standard deviation of 0.09, which give a 5 to 95 centiles of 35 to 53. And in his experience, you see this is a graph from his papers, all the cases with hard defects, just one was sitting here, all the cases with hard defects and microdeletion had a low TT ratio, much lower than normal. So there was no overlapping between the two groups. However, more recently, other group, actually Lindsay Allen and her group from the King's, have re-evaluated the issue, and in their experience, there was a kind of overlapping between especially babies with hard defects and those with hard defects and microdeletion. And so the conclusion of their paper was that it was useful, but it was not so useful to define whether it was a microdeletion or not. Probably the difference in the performance are due to two things. The first one, if you compare the trivessa and trachea view in the two papers, this was the one by Shawi, and you see here that actually this is the real trivessa and trachea view because you have the V shape of the two ductal and aortic arch, whereas the paper may be just a case, but the paper allegedly showing the same image by the papers of Bataeva and Lindsay Allen actually did not demonstrate the trivessel and trachea view, but was sitting just a few millimeters below that, where the aorta is still in cross-section. So this may have been one of the reasons why the performance of the TT ratio was not the same. And the second issue is that it is easy to define the anterior border of the aortic arch in normal condition. But if you have an abnormal condition, a truncal abnormality such as in this case, and I run from the tie box downward where the single vessel is here, and this was a common arterial trunk with the microdeletion, you do not know actually where to put the measurement, at least not being familiar with the TT ratio as Rabi was. Here, here, here. So these two factors, probably an ill-defined level of where to take the TT ratio in Bataeva's papers, and also a clear difficulty to where to stop the measurement in case of abnormal upper mediastinal anatomy, are the reason why the results of the two papers are slightly different. So what to use? Probably the one proposal may be, and I leave with this slide, why not try to replicate the measurement that you see here, that this can be done also in very early gestation, to use again the TT ratio, but to anchor it sideways at the level where you have the two markers of the tie box. So in this case, you will always have a posterior border given either by the aortic arch or by the nominate vein if you have a step more cranial to that. And so we are currently working on that. After Merkel and Monti, after our president coming to Germany, we are currently working on this project together, as you see. However, this is the tagline, keep in mind that there is no way to replace the FISH analysis with any non-invasive test, at least so far, for the microdeletion, because as I was telling you before, it is not present always, neither in case of microdeletion nor in case of the George syndrome. And I thank you for your attention.